Hello, I'm Dr. Linda Bradley, and today I'm so happy to have been invited to speak to you about something I'm passionate about. And I'm going to let you know everything you want to know about fibroids and endometriosis, but you were afraid to ask. I am professor of obstetrics and gynecology and reproductive biology at the Cleveland Clinic in Cleveland, Ohio. If you need to get a hold of me, my email address is bradlel@ccf.org. So what are our goals today? I want to tell you about fibroids, what you need to know about endometriosis, what are your treatment options, and what are effective tools and techniques that you can use to talk with your physician. So I've entitled this section all about the F word. Get the facts about fibroids. Well, fibroids are a big problem. You'll hear the term fibroids, leiomyoma, and even sometimes tumor, but these are the words that we speak to patients about. Most patients will develop symptoms in their 30s and 40s, and when you get to menopause, they go away. A good thing about aging. 50 to 80% of women will develop fibroids, and as we'll see, women from the African diaspora have the highest risk. The good thing to know that if you're diagnosed with fibroids, just on a general exam, that almost 25 to 50% of patients will have no symptoms, and you don't need to worry about them. And the other thing, they're rarely malignant. So what are the takeaways today? I want you to think as we talk about fibroids that each fibroid is like a thumbprint. Or I'm from Cleveland, it's like a snowflake. Each fibroid is unique and one of a kind. When we think about the uterus or the womb, normally it's about the size of a lemon. But as we'll see in some pictures and the stories that might be told, the fibroids invade the uterus with small growths and can stretch the uterus from the size of a lemon to even the size of an orange, grapefruit, and I've seen fibroids the size of a turkey or basketball. It's very interesting. It's been shown that when you go to your doctor, you should leave knowing, if you've been told that you have fibroids, what's the size of your uterus. We usually speak of it in terms of weeks of pregnancy or months of pregnancy. Also, some doctors may say your uterus or fibroids are the size of a baseball, or the size of a football, or the size of a cantaloupe. It turns out that when a patient comes to me and tells me that her uterus is the size of a piece of fruit, turns out that she was most likely seen by a woman physician. Women tend to tell their patients the size of the fruit. Guys really speak in the terms of football, baseball, and basketball size. So I just thought that's fairly humorous. And these are just a few pictures of what fibroids might look like. We'll see here pictures inside the uterus. This is the space where a baby would be, the space where your periods start. These are fibroids in the intracavitary space, and they can be associated with infertility, miscarriage, heavy bleeding. This is me doing surgery. That's my hand, and a big, big fibroid that's about the size of a large cantaloupe. Sometimes fibroids will even prolapse. This is a pelvic exam where it looks like a baby's head, but it's coming through the vagina. Again, the location will vary. The size, look at this patient who we've taken out tons of fibroids, the number, the location. And as we'll see in a moment, because they can stretch, especially those in the muscle, they can make you look pregnant. And this is a woman whose fibroid was almost the size of a 9-month pregnancy. So again, your doctor will talk to you. Size, number, and location will make the difference in the treatment options. We often say that this is a bimanual exam, just examining a patient, that we cannot tell a book by its cover. We have to know what's inside the uterus, and we'll need to do imaging, things like ultrasound. This is a patient who has a large fibroid. This is a hysterectomy, and no longer what we need to do a hysterectomy for a fibroid like this. I'm able to go through the cervix, into the uterus with the hysteroscope and literally cut away these fibroids. So again, knowing the location with imaging like ultrasound, MRI, saline infusion sonogram, hysteroscopy, these are terms that you need to know in terms of how your doctor will identify location. It's sad that this patient ended up with a hysterectomy. This is a small little fibroid inside, and nowadays This is the only abnormality. I would take a hysteroscope and just cut this away in a simple procedure taking 30 minutes that we go through the vagina. Patient goes home an hour or two after surgery and back to work within 48 to 72 hours. This is a picture that I have of a patient, was 28. She had about 8 fibroids inside the uterus. This is me using my flexible hysteroscope. Multiple little growths, these smooth tissue that grow inside, and she bleeds and bleeds and bleeds. Some patients who have similar located fibroids may have recurrent miscarriages or infertility. Again, the pre-op workup with a hysteroscopy would allow me as an outpatient to just resect the fibroids that are inside. So again, there are different options depending on size, number, and location. This is a patient this is the cervix, and here's a fibroid coming out. It just almost looks like a baby has been delivered, and we can do what's called a vaginal myomectomy. Sometimes they begin to prolapse, can lead to pain, discharge, and heavy bleeding. So we've seen some pictures, and what are fibroids? Well, they're generally benign growths of the uterus that are made of smooth muscle and some other material. There's a high prevalence, there's a lot of health impact, a lot of money that's spent, and patients will often ask, well, doctor, what causes the symptoms? The reality is that we really don't know, but it costs the healthcare system more than $34 million per year. Fibroids occur in more than 80% of women just based on ultrasound. And by the age of 35, 40% of women will have fibroids by ultrasound. And by the age of 50, 70% of ultrasounds will identify fibroids. Symptoms are present in 25 to 50% of women. So what are the symptoms? We tend to think of them in certain categories, such as bleeding. If the uterus gets very large, your tummy can push out. You can have bloating. You can have miscarriages, infertility. Sometimes your social life makes you sad because you're bleeding so much, you can't go out, you have socially embarrassing situations where you've bled through clothing, soaked your mattress, can't travel, can't work. Sometimes as the fibroids get bigger, the organ in front of the uterus is the bladder, and some patients have frequency of urination, they can't urinate, they get up at night 2 and 3 times to urinate, and these are other related symptoms. And then finally, some women have significant pain during their periods and even throughout the month because of the fibroid-related symptoms. We know that fibroids are an equal opportunity problem, and they have a huge health impact. Unfortunately, we find that hysterectomy, which 1 out of 3 women has by the age of 60, the more common causes are not due to cancer. Only 10% of hysterectomies are due to cancer. The other often are due to related conditions from fibroids, bleeding, and even things, as we'll talk about, with endometriosis. And again, we're looking at new options for treating. So I've just spoken with you a little bit about the pain and pressure. Very seldom, women who get pregnant with fibroids may have obstetrical problems. This could include things like preterm labor. If you deliver, the afterbirth stays inside. We call that retained products of conception. Sometimes instead of the baby's head coming through the pelvis, there's malposition. It's breech. The baby's head is to the side, and sometimes that can be an obstetrical problem. Sometimes during pregnancy, because of so many hormones, there's a lot of pain and discomfort because of what happens to the fibroids during pregnancy. So again, what do we know? About 600,000 hysterectomies per year and only about 125,000 myomectomies. And I want you to let you know, especially if you want children, please look for a surgeon that can offer myomectomies, which is a uterine preserving procedure that allows the fibroids to be removed, your periods resume, and pregnancy, if there are no other issues, can be possible. So what do we know? We know that fibroids are more common among women from the African diaspora. In fact, 3-fold more common. What else do we know about this group of women? They're larger, they occur earlier, they have more symptoms in terms of quality of life issues. We don't know everything about fibroids, but we do know that they're associated if your periods start early, and we're talking about ages 9 or 10. If you're older, your late 30s or 40, if they run in family, if you haven't had kids, if you're overweight. Also, it's associated with irregular periods, something called polycystic ovarian syndrome. It's higher among people that have diabetes and hypertension. Now, the sadness about this, and I was involved with this study, is that 968 women were surveyed, and we asked them several questions. We found that many women waited about 3.6 years before even getting treatment. 41% saw more than 2 healthcare providers for diagnosis. 28% of women miss work due to their symptoms. And because they bled so much, had pain, had anemia, the 24% of them believed that their symptoms even prevented career potential advancement. So again, why were women waiting so long to get treatment? So often these women think that the only solution for them is a hysterectomy, and they want to avoid surgery or still want to have kids. And what do women tell us also in the survey? Almost 80% said that they did not want an invasive surgery, i.e. hysterectomy. 51% said that they wanted to keep their uterus, even if they weren't going to have any more kids or have kids at all. And if the women were under the age of 40 years old, about 43% definitely wanted their uterus saved so that they could have kids. So when you go to your physician, as you think about symptoms, it's really important that your doctor know about what we call QOL, or quality of life. Make sure you start journaling your symptoms. How does the fibroid-related symptoms affect you? Your sexual functioning. Do you not have sex because you bleed every time after intercourse, or you're bleeding all the time and you don't want to have intercourse? Does your body image, because your uterus is large and you might look pregnant, does that affect you? Do you feel like you have loss of control? You can't go dancing, hula hooping, rollerblading, swimming, skiing, wherever you're going to do. Loss of control because you're bleeding where you have to change your pad every half hour, every 15 minutes, and you just have loss of control. And then sometimes patients just say that they feel hopeless. So again, we've talked about the symptoms, and let's go and dive into this a little bit more. So I always say, I love this picture. This is a woman wearing a diaper. You shouldn't have to wear a diaper having a period. It shouldn't be that heavy. And if you are wearing diapers and Depends and putting a chucks and towels and rags in your underwear because you're bleeding heavily, you really need to see a gynecologist. So what are the symptoms? Prolonged bleeding. Some women just have a chronic bloody discharge or watery discharge or pink discharge. We call that leukorrhea. Some women get their periods, but a few days before, always staining, or after their period. It just takes longer for the period to end. Some women bleed every time they have intercourse. Some women come in, they're so anemic that they have pica. What's that? Unusual cravings for ice, starch, and dirt. Some women are really embarrassed to tell us that they're craving and eating ice all the time. Share that symptom with your doctor. And again, in a typical fibroid population, 85% of patients complain of abnormal bleeding, and we see that this is important and another reason to keep a journal. They also say that they're gushing and flooding, that they're doubling up pads, tripling up pads. I had a patient yesterday who puts in 3 tampons at a time and changes every half hour, plus wears a pad just to get through her workday. And we tend to sometimes find that bleeding is higher among women with fibroids than those without. And it turns out, surprisingly, that sometimes the location of the fibroid does not make a difference in terms of how much you're going to bleed. What do we know about hysterectomies? About 75% of hysterectomies occur between the ages of 20 and 49. That's not good if you want to have a baby. And also, we are finding that we have new ways to treat fibroids with minimally invasive modalities such as laparoscopic surgery, robotic surgery, vaginal myomectomies if it's necessary, or hysteroscopic surgery. We really don't want women to get major surgeries where their whole abdomen is open. Find a doctor who is trained, often who's done a fellowship, in MIGS, known as minimally invasive gynecologic surgery. The good news, although we use the term tumor, and I hate that word, I usually use the word fibroids or leiomyoma, the word uterine sarcoma. That means a fibroid has cancer. It's rare. It's 1 out of 300 to 1 out of 350 patients, and your doctor will know how to check for that. The average age of hysterectomy is about 42.7 years, and the median is about 40.9. So again, it's your choice of what you have done. Hysterectomy is a definite treatment. That means no periods, the uterus is removed, you don't need a pap smear, you can't have babies, and fibroids will not grow back. But again, the word myomectomy, which is a uterine preserving procedure, should be offered and should be the only option if you want to have children. With hysterectomy, it's a low risk, but compared to myomectomy, there's a greater risk of injuring your bladder or bowels or the tubes that carry your urine from your kidney to the bladder. The physician must re-support your pelvic organs to prevent prolapse, and we are finding that some women who have hysterectomy, even if the ovaries are preserved, may go into menopause or have menopause-related symptoms 2 to 3 years before. So I'm just going to briefly go through the types of surgical procedure that you should know, and these are just terms. If you want to keep your uterus, the medical terms are myomectomy, and it can be done based size, number, and location. This is a large fibroid here. Okay, the woman looks pregnant. The doctor may need to do a laparoscopic or robotic myomectomy to remove all of those fibroids. This fibroid is located inside the uterine space, and this is treated with a hysteroscopic procedure. These are both pictures of hysterectomies, but doctors could now just take out these fibroids that are present with different technology. So when you go in to speak with your physician, know the size, know the location, know the number, and then what are your options? Because a patient like this with a huge fibroid, this has to be approached with laparoscopic or robotic surgery. That's not a hysteroscopic procedure. We have to take out the bulk of those symptoms. Again, just more images there. And again, these are non-uterine sparing procedures. So I want you to know that there's a lot of myths. If you find a doctor saying that the surgery's too hard, it's too bloody, it can't be done, they don't do very many, get a second opinion. It's time for us and for you to get rid of the myths. It is safe. It is effective. There are ways and medications that we use during surgery to make this as safe and less blood loss than a decade or two ago. So again, many new treatments. Why do I want you, if you need surgery, to have it done by a surgeon who does minimally invasive surgery? Well, there's less scarring. You go home that day or the next day. You need less pain medicines. And we know that people sometimes, especially women, get addicted to pain medicines by C-sections and by surgery. You go home quicker, you can get back to your activities within 2 to 3 weeks. Overall morbidity, meaning complications, is less in a big open case, and believe it or not, the cost is less. I'm going to mention another term that a doctor may recommend. It's called UFE, or uterine fibroid embolization. This is just showing the uterus and the major blood flow that goes to the uterus. These are fibroids, and each fibroid gets blood flow. A radiologist, not your gynecologist, but we work collaboratively, can offer what's called a uterine fibroid embolization. They can go really through a vessel in your arm to thread all the way down, believe it or not, to the uterine arteries, and or go through the groin to access the uterine arteries. And what we see, this is a picture before. They take a picture. This would be a big fibroid. And what uterine artery embolization does is to block the flow of blood to the fibroids. So it kind of starves the fibroids. When the fibroids are starved, they shrink, they get smaller. So if you're having bulk symptoms, urinary frequency, constipation, it gets smaller. This shows the massive blood flow, and this is after particles are put in that stop the flow of blood. They're starving. You don't see this blood flow. These are easy pictures, even if you're not a doctor, to see. This woman had heavy bleeding. Look how big this fibroid is before, and over time it gets smaller and smaller so that she has less symptoms. This lady had pain. This white space is the urine in the bladder. She was going to the bathroom all the time. So we have a huge fibroid here, And we follow the patients, and over time, because it's starved, it shrinks. Again, seeing is believing. Big fibroid here, pressing on the bladder. You barely can see it 6 months later. This procedure could be offered only to women who do not plan on having children, but don't want a hysterectomy. So you have to work with your physician, and knowing whether you want kids or not is very important. So again, you don't want childbearing, you don't want surgery, and you may have complications for surgery. And overall, we know that in the right patient, that it's durable, it works. There are about 35,000 cases per year. 80 to 85% of patients who have heavy bleeding, pressure, feel better. And quicker return to work. That's 7 to 10 days. You go home the next day or even the same day. Less pain. And increasingly across the country, as I mentioned, 6 to 8 hour stay. And back to work quickly. Low complication rates. Now, this is another procedure called MRI focused ultrasound, and basically it's an outpatient procedure done by a radiologist. A patient goes into an MRI booth, and basically there's no hospitalization, there's no cutting, you're given some sedation, and basically with the ultrasound, it can detect the fibroids and basically heats the fibroids so that it gets heated, and over time it will shrink. So again, another technique often being offered to women who want children. Another quick picture, I love hysteroscopy, that's my specialty. Big fibroid inside the uterus where pregnancy would be. This lady would not be able to get pregnant. This is a fibroid afterwards. It's removed. If she wants pregnancy, she'll be fine. Her bleeding is all better. And this is just the instrument that we use to go inside, and we can cut, desiccate, remove these fibroids. Some other terms that your doctor may talk about, something new in the last FDA approved called the Assessa system. It's a system that's done laparoscopically in order to basically desiccate, heat the fibroids, and it's done through a laparoscope. Your doctor may just talk with you about that. Sometimes we start with medical therapy. This can include birth control, IUD that's safe to use, medicines that are used to stop bleeding, medicines that decrease the amount of bleeding. Sometimes if you just have pain, an NSAID like Motrin, Advil, Aleve, Meclamin, Ponstil, many different things, Anaprox can be used. And again, some new terms that you need to know about. There's Depolupron, an injection that's given on a monthly basis. That's not a hormone. It suppresses hormones to stop your bleeding. And the newest drug called Orion, just released by the FDA in May of 2020, a pill that's taken daily to stop bleeding. I'm just going to mention Lysteta or tranexamic acid. It's been available for 30 years in Europe, Canada, India. In America, it's been available since 2009, 2010. And it's a pill that's not a hormone, that's only taken 2 pills every 8 hours during your cycle for just heavy bleeding. You can't be on birth control. We don't use it if you've had a stroke, heart attack, or blood clots. But for women who have regular, predictable, extremely heavy periods, is only taken during their cycle. If you have cramps, you sometimes will even get better by taking this medicine, or you can add an NSAID to it. This is the newest medication called Orion. It's FDA approved. You take it every day, can be used up to 2 years. And 7 in 10 women who took this medication, as you can see, bled less. So your doctor may talk with you as this is the newest medication off the block, so to speak, depending on your size, your numbered location that you may get treated with. So I want you to know about that. So as it relates to fibroids and other things that we're going to talk about now in terms of endometriosis, what do we know that you really, really want? We really know that you need time to talk to your healthcare team about your problem. This may take a couple of visits to talk with the doctor, get images, come back, go over results, talk about medical therapy. We also know that you want to be taken serious, that your symptoms matter. We want you to come with a list and ask questions and to see what we can do in terms of offering treatments. You want to hear about medical treatments and if surgical treatments are an option, do they do minimally invasive gynecologic surgery, and to offer that rather than the typical large surgeries that we used to do for these problems. So again, as it relates to fibroids, let's look at all the options. You've heard about most of them today. Look at the pros and cons of surgery And if you're looking to have kids or want to keep your uterus, what are some of the alternatives? So I hope that this was helpful in letting you know everything about fibroids. Now, briefly, we're going to talk about endometriosis, another common condition. Again, we don't know exactly why women get it, but it can affect your body image, cause pain, infertility, have discomfort with intercourse. If you have such pain, you may miss work, activities, and the like. And the most common symptoms are bad cramps, heavy bleeding, pelvic pain, back pain, pain with intercourse, pain when you have a bowel movement. You can alter this with diarrhea and constipation. Sometimes bloating, nausea, and vomiting. Pain in the inguinal glands where your groin is. And sometimes it involves, meaning endometriosis involves the bladder. You can have burning with urination, frequency with urination, and even blood in your urine. Some patients will even have pain with exercise. What do we know about endometriosis? Again, another equal opportunity disease affecting 10% of women, about 190 million women worldwide. Again, it's pretty sad, but many women, believe it or not, suffer 7 to 8 years before a diagnosis is made. They're just not taken seriously, they don't have imaging, they aren't given a trial of medication. It turns out that one of the predominant symptoms, and even it occurs in teens, is that cramps, bad pain with the cycles are seen in young women, and 75% of women who don't get better with conventional medication for cramps can have endometriosis. So what's the prevalence? Like any disease, some people have no symptoms, 2 to 11%. Some women who can't get pregnant, when they further are worked up, 21 to 47% of women have endometriosis. And sadly, for women who have chronic disabling pain, or we know it as chronic pelvic pain, 71 to 81% of women have subsequent diagnosis of endometriosis. Who's at risk? Anybody that's a woman, more commonly in your 30s and 40s, but it can occur in adolescence. It's more common in women who haven't had kids, who have periods longer than 7 days, whose periods are shorter, those who start their periods before age 12, and it runs in the family. If your mother or sister has endometriosis, you may have a greater risk. Talk to your healthcare provider. I love telling my patients just to keep a journal or pick up your phone and go to the notes page and just take notes about your menstrual cycle and your symptoms. When you come in, that way you have the symptoms, you can tell the doctor or your healthcare team, when do you have the pain? What's scoring pain from 0 to 10? Is your pain occurring just when you're on your cycle, outside of your cycle? What makes it better? What makes it worse? What can't you do? Do you have pain with intercourse? Do you have pain with bowel movements? It's very, very important to note and track these symptoms. I just wanted to, this is a laparoscopic picture. It just shows these powder burns. It looks like black, bluish color. Okay, this is inside the uterus. These are the uterosacral ligaments. And these powder burns and lesions can be seen on laparoscopy and even sometimes with MRI. We at the Cleveland Clinic have specialized MRIs that can help diagnose some of these fibroids, but endometriosis that we can see in these special places. The more common organ that it goes to, this is the ovary, and it's almost as if blood goes back and regurgitates, and it looks like Hershey's chocolate syrup. The ovary is swollen, and if we drain this cyst, it's black to brown color. We can see these powder burns. So again, there is some diagnostic imaging, and even with things like ultrasound, depending on how much endometriosis you have, they may be able to pick up. Again, some scarring. We can see the bowel is stuck to the back. This is the uterus, and the bowel is adherent. So you can see that this might be associated with pain. And, again, is it just cramps or is it endometriosis? We tend to say that everybody gets cramps. And if you get relief from just over-the-counter pain medicine, you're probably fine. But if the pain is lasting more than 2 days, keeping you from doing things, and even remains after your period, you should see your doctor. Again, we are diagnosing endometriosis more often in teens. Even it can start with the first menstrual cycle. Same thing, if you're a mom or grandma of a teen that's really missing work, activity, schools, hobbies, not doing anything, have them seen by their pediatric physician, and sometimes a referral to an adolescent gynecologist is made because we are picking this up earlier. Again, having difficulty getting pregnant, an infertility doctor will look at your symptoms, and again, for many reasons that we won't go into, infertility may be associated with endometriosis. So again, we don't know what causes it. One of the old theories called Sampson's theory is that the blood, instead of coming out through the vagina, goes back through the tubes and implants in the peritoneal cavity, the pictures that you just saw. But rarely, we might see it in a C-section scar, and a scar near a hernia repair near the belly button. We don't know, but we think that immunity also has something to do with getting or acquiring endometriosis. So again, tell your doctor if you're having aching discomfort, very bad cramps, pain with urination, tired, having other pain syndrome, pain with intercourse. You've stopped having intercourse because pain with deep thrusting. And again, we saw earlier that it can occur in different locations, even in the lungs and near the diaphragm, which is in the upper abdomen. So your doctor, based on your symptoms, will look for this. So how will we suspect it? What are the clues? If you have recurrent symptoms during your cycle, it's probably a likely option that your doctor will examine you during your cycle because that your symptoms are worse. And it seems maybe unusual or not common, but the doctor may also do a rectal exam to take a feel behind the uterus to see if the ovaries are fixed, if they're tender, as we just showed, if you have any involvement in the rectum. But the doctor is feeling to see if the uterus is tilted, if it's tender, if it doesn't move, is very rigid. These can be symptoms and suspicions for endometriosis. So how do we decide who's going to be treated? We determine, is this chronic? Is it acute? Do you have other comorbidities? Do you plan on being a mother? What are other long-term consequences that you may have? Are you going to lose your job because you're missing so much work or activity? Have a problem with school attendance and all of that. And then again, what is your preference for treatment? Our major society called ACOG, American College of OBGYN, recommends that doctors first try 3 months of things like NSAIDs, Motrin, Advil, Aleve, all the things we've talked about. And if you're a candidate to use birth control pills, why? Birth control pills lead to less bleeding. We can have you on the birth control pills to avoid a period. If there's less bleeding, there's less cramping. And then they say, as doctors, as we look at putting the pieces of the puzzle together, if you're not better after 3 months, to consider a laparoscopy, which is a brief surgical procedure to look inside the abdomen and to determine if you have any of those spots. If you don't want surgery, then we can look at medications that we'll talk about. And when we look at the options for when we say birth control, it's a low-dose pill, it could be a NuvaRing. These are normal medications that can be advised in women who have no risk factors for use. So again, most of the options mimic a pregnancy. It creates a progesterone-like effect, so it makes the tissue less tender, less scarred, and helps the symptoms. So birth control pills is often used, but if you smoke, you've had a heart attack, you're over the age of 35 and smoking, we have to look at other medications to stop the periods or to create what we call a pseudomenopause. These are medications that you'll hear about. Just to keep you up to date, some are called Lupron. It's an injection every 3 months. An older medicine called Danazol in low doses can suppress the periods. There's GnRH agonists and what's called aromatase inhibitors, letrozole that may be used. And the newest is elagolix, which is an oral GnRH antagonist that suppresses these hormones and makes you not have periods. It happens quickly and may treat the related symptoms. What about surgery? We try to avoid it unless you have acute pain, if the ovaries are swollen by MRI or ultrasound, if you're trying to get pregnant and can't, if we're not sure after imaging and pain doesn't go away, if we feel that the disease is deep-seated, meaning we feel rectal nodules, we can see lesions in the vagina, and we know that you have adhesions. Surgery, usually in the form of laparoscopic surgery or robotic surgery, is indicated. And it's also important, like any disease, that if you have endometriosis, that you take care of yourself. Good diet, exercise, things like acupuncture, yoga, have also been shown to help with symptoms. So lifestyle matters, and working with taking care of yourself combined with your physician can be of help. So we talk about shared decision making, you talking with your doctor. These are the things, and it's kind of summarized here, that we've talked about. Taking medicine like NSAIDs, monitoring your symptoms, and then we want to make sure that you are compliant, and then we can move on to things in second or third tier, with surgery being last. So in general, women with endometriosis, as with women with any pelvic pain syndrome, I know that you're asking us as your healthcare providers to take you seriously. And as we've become smarter about this disease and have new tools, we are listening. We want you. Feel free to talk with your doctor, to share your symptoms. Don't go 7 or 8 years just thinking that this is something that women have to deal with. Yeah, it runs in families, and maybe your mother and auntie and grandmother had the same symptoms, but this isn't your grandmother's age and your mother's age. It does run in families, but there are new things that we can offer. And so talk with your doctor about that. Think about whether or not you want to be pregnant, because in doing so, we'll know what treatment options are best for you. So I hope that I've been able to tell you everything you want to know about fibroids and endometriosis, but you were afraid to ask. And I hope that your questions were answered. But just in case they weren't, or you have more questions, feel free to reach out to me. Again, I'm Dr. Linda Bradley, Professor of Obstetrics and Gynecology and Reproductive Biology at the Cleveland Clinic in Cleveland, Ohio. And my email address is bradley@ccf.org. It's been great talking with you today. To your good health. Thank you.